whereas in the United States, about 40 million don't have any insurance. A number of other millions don't have adequate insurance. And the government only covers people who are elderly and people who are very poor. So healthcare, therefore, distinguishes us from Americans, and it causes an unaccustomed feeling of pride and superiority. But the system is also a symbol. It's a symbol of what it means to be Canadian, and it crystallizes in one program the fundamental values of our political culture. Political culture refers to values, attitudes, and beliefs about government. In short, it is a belief about what the role of the state should be. To what extent should the state intervene in our lives, in our society, in the economy, etc. And these values demonstrate a commitment in Canada to social justice through collective action, because we pool our resources and we provide healthcare to everybody. Now, as many of the programs that did this in the past have been cut back or eliminated, this remains the single emblem of Canadian values, and this is why it is so highly cherished. Now, there are many critics who scoff at the idea that the Canadian identity should rest on such a slender base. There was a column written by Globe and Mail columnist Lyciane Gagnon some years ago, and she complained that Medicare has acquired a quasi-spiritual dimension as a major part of the Canadian identity. She says, and I quote, "In the eyes of many Canadians, Medicare is what separates Canadians from the United States. Medicare feeds the self-righteous tendencies of Canadians. It allows them to think of themselves as morally superior to the Americans." Her column was titled, "What Do You Do with a Sacred Trust?" And she laments the fact that we do not suffer critics of public health care gladly. The hapless critic is accused of promoting a selfish and brutal two-tier American-style system. What can you do with a sacred trust? All you can do is sit down, shut up, and honor it. Now, during the recent healthcare debate in the United States, the problems in the Canadian system were mentioned frequently, and Canadian healthcare was dismissed as inferior socialized medicine. Now, ironically, the system in place for veterans in the United States, the Veterans Health Administration, which covers about 8 million veterans, has a centralized, not-for-profit, single-payer system, and it works extremely well. And we could perhaps learn some lessons from it. It employs thousands of medical professionals and runs hundreds of hospitals. Now, given healthcare's status, it's not surprising that those who want to bring about change need to discredit it. One tactic is to chastise Canadians for being backward by accusing them of resisting modernization and for sticking with a public monopoly with no consumer choice. There are consulting firms like Ernst & Young that are exercising their considerable skills on behalf of clients who want to break into the Canadian market, which is considered the biggest unopened oyster in the Canadian economy. This is a billion-dollar industry, and make no mistake about it, it is an industry. So they advised their clients to pave the way to a fully integrated role for the private sector in the healthcare system by proceeding cautiously. So initially, what they advised them to do is to bid for non-core services like laundry, dietary, and cleaning services. And in the long term, the strategy is, and this is a very interesting phrase, effective management of public perceptions hostile to private sector participation. And this is to be achieved by a carefully crafted public relations campaign to educate the public on the virtues of the private sector and the deficiencies of the public monopoly that offers no choice. So PR firms are advising clients to lobby the government to change public policies so that a cost-benefit analysis is the primary criterion to measure success. So such measures as quality of care, health outcomes, universal access have to be de-emphasized. They've also been advised to avoid mentioning the American system, which is feared by Canadians, and to instead talk about European models which have a mix of private and public, and we will be coming to that in a minute. Now, there are numerous other streams of criticism that are designed to force us to see the error of our ways. Critics argue that billions of dollars are being poured into healthcare, and they're crowding out other priorities, like education, like funding Olympic athletes and other worthy causes. So that's the campaign to manage public perceptions. Now, turning to how well-informed Canadians are, I would argue that at a gut level, the Canadian healthcare system and want to maintain the current model. However, they're also very confused. There's intergovernmental squabbling about Ottawa's contribution and its commitment to healthcare, and the whole issue of funding is exceedingly complicated. And I think it would be fair to say that most Canadians don't understand how the system is funded and are vulnerable to the charges that, it's unsustainable and so on. That was one of the reasons why I wrote this little booklet. This is not shameless self-promotion because it's available electronically. I don't make any money out of it. And I explain how the system is funded. So the bickering between the federal government and the provinces adds to this perception that the public sector is incapable of doing anything well. Now, there's evidence in peer-reviewed journals that a not-for-profit system is cheaper, it's more effective, and it's more efficient than any other. I'm not saying that our system is perfect. I know we have got tremendous problems. The Alberta government has tried to bring about change on more than one occasion and has backed off as a result of public resistance. And because of these threats, perhaps, Albertans are better informed about the merits of the current system than people in other parts of the country. And Gerard Boychuk from the University of Waterloo has found that Albertans are less receptive to private funding and insurance for health services than Canadians on average. And this is what he says. Alberta is the only province in which public perceptions were that greater private involvement would lower the quality of health services. Now, people in other provinces would be surprised to hear this finding because we have a reputation in the rest of Canada of being extremely right-wing, self-reliant, and selfish, and all kinds of other nasty things. But that's another story. But the wariness, I think, in Albertans comes from this very vigorous debate that we have had about healthcare. We have had a more vigorous debate in Alberta than they have had in any other province in Canada, I would argue. Now, there is an air of crisis hanging over the healthcare system, particularly in this province, and I guess you guys must have talked about some of this in the morning. I'm sorry I wasn't able to be here. Timely access is a major problem, and fears about sustainability are causing concern. So what is being discussed at the moment is whether we should move to a mix of private, for-profit, and public healthcare in this country, to see whether this would address problems of access and sustainability. And there have been calls to investigate European models, which seem to provide cheaper healthcare with a public-private mix. So that's what we're going to look at now. This is a cartoon that appeared in the United States during their campaign, healthcare campaign. And you can see the huge lineup and somebody has died, and so, this person says, you're one spot closer. And I think it sort of epitomizes what they think of our system. So when you're looking at other models, these are the sort of key elements that are found usually in European models and in the Canadian model. The notion that it's a social good, that there's solidarity comes into it, that there's mandatory participation, tight public regulation, fairness for the community, and very importantly, a legitimate role for government. And there are different ways of funding. One is predominantly through taxes, which is the Beveridge model, and the other is social insurance contributions, the Bismarck model, or a combination of the two. So I'm going to look at Britain and Germany. Britain is an example of the Beveridge model, and this is how much they spend per capita. So it's $3,129, and in Canada we spend over $4,000 now. The percentage of GDP in Britain is 8.7, and in Canada it's gone up to 10.4. I must say that some of these figures, I've grabbed them quickly because I only had a short time to do, and there are maybe some conflicting figures. The number of physicians per 1,000 population, 2.2 in Britain, 2.1 in Canada. The coverage in Britain is greater than ours. They have medical and hospital services, prescription drugs, dental care, and some eye care as well. It's funded entirely through taxation, and their budget at the moment is around £100 billion. That was in 2008-9. But patients in Britain can get private insurance run by the independent health sector. The NHS, actually, the National Health Service, actually employs physicians. They are salaried. It's the 4th largest employer in the world. I had to put this in because I just was blown away by it. Behind Chinese Liberation Army, Walmart, and the Indian Railway. So it's a huge enterprise. It is a 2-tier system. Doctors can practice publicly as well as privately. 13% are covered by, have some private insurance. They say that the mainstay of the private sector is hips, hernias, and hemorrhoids. In other words, simple, easy, routine things that need to be done. And the wait for scans is 9 weeks if you're on the NHS, and 2 days if you're a private patient. Doctors are salaried, as I just. Now, the system is similar to Canada in the sense that there are no charges at the point of delivery. Patients are assigned, I think were assigned a GP. I think they have more choice now. There are primary trusts, and these trusts are responsible for looking at the healthcare system in a defined local area. The hospitals are managed by public trusts. There are waiting lists for patients without private insurance. And if you have private insurance, you can buy faster care, and it's often in the same hospital that is paid for by the NHS. And practitioners work in both public and independent systems. The NHS funds about 3/4 of the residential care and nursing home places in the independent sector. So they're not built and run by the public sector, they're run by the independent sector, and some of those are extremely expensive. Now, everything I've said so far about the system in Britain is about to be changed. They have a bill which just gone through the House of Commons. It was 500 pages long, and it's going to completely overhaul the system. They want to abolish these primary care centers, trusts, and turn over 80% of the budget, which would be about $80 billion, to consortiums of GPs who are going to run it. And it's not yet clear what happens when they save money. There are some fears that some of them are going to float these consortiums on the stock exchange. So someone's going to make money, obviously. They want to shed about 24,000 people in management and introduce competition at every level of the system. There has been some pushback. The Liberal Democratic Party, which is in a coalition with the Conservative government, had a party convention last weekend, I think. And they're against these changes to the NHS. The other criticism comes from the Royal College of General Practitioners, and the chair was concerned about fragmentation, duplication, with competing private, public, and voluntary sector providers. So she said that it would deliver less choice and fewer services, so they're very concerned about it. So the reform might prevent GPs from providing appropriate medical treatment if they're looking to save money, and if that money then comes back to them, which it did when Thatcher made some changes, then you have to ask yourself, are they going to do what is actually necessary? The British Medical Association does not want competition on price, and they also have criticized this whole campaign to reform the system as being having too little transparency and public input. Okay, the next one I'm looking at is Germany, and in Germany the per capita spending is 3287. The share of the GDP is 10.7%. They have more physicians than we do, 3.4 per thousand population, and they have a lot of specialists in Germany, 2.3 per population. But coverage is very extensive in Germany. They have hospital and medical care, prescription drugs, physio, occupational therapy, home care. And they even have an income supplement for people when they are ill and they have to go on sick leave. I think it's 78 weeks over a 3-year period. Now the financing is based on statutory health insurance. So it's mandatory. They have to take out this health insurance. So there are contributions from the employer and the employee. So it's like a payroll tax, and the employer pays 7% and the employee pays 7%. Low-income workers only pay 10%. The employer only pays 10%. Recently, they brought in an additional charge for dentures and sick pay. 9% of the population has supplementary health insurance. And since 1995, they've had an additional levy of 1.7% of income for long-term care insurance, and people have to start paying this as soon as they start working. The money goes to independent sickness funds, and this pays for care that is chosen, for care which is chosen by members. Now, the system does not have gatekeepers. Patients can go directly to a specialist. They can change their own doctors, and they've got so many doctors that people, walk into an office, they see somebody waiting, and they walk somewhere else. And if they don't think that the doctor treats them properly, they just go to someone else. And some people have more than one doctor. Since 1996, they've sort of streamlined the system, and there are about 200 sickness funds which insure workers, and they're competing with each other because now people are more likely to move from one to the other. There are co-payments that they have to make for doctor's visits, so hospital stays, prescription drugs. They're relatively minor. The total co-payments are capped at 2% of gross income. So in other words, you cannot be bankrupted by, some serious illness. There are some groups of people that can opt out of the public system and purchase private insurance, but once they do that, they cannot opt back in. 10% of the hospital beds are private for profit, but the rest are public or not-for-profit. The government's role, of course, provide the regulatory framework. Now, Germany is a federal system like Canada, but their federal system operates very differently. The state representatives negotiate fees and providers of the sickness plans, and they have social courts that rule whether, if there's some dispute about health between the plans and individuals. There's strict regulation of private insurers, and they refer to this as manacled competition. I guess the conclusion is, what lessons are there in this for Canada? And one of the points I think that is really important is that each system has its own problems, and you cannot slice one system out of some other country and expect it to work the same way. There are historical, institutional constraints. The question is, are Canadians willing to move to the Bismarck model by making contributions off their paychecks? Incidentally, in both France and in Germany, which used a similar system, government is becoming concerned because if employers have to pay such a chunk for healthcare for their employees, would they be likely to hire people, or would they be, and there's high unemployment in Germany. If you're unemployed, the government pays. So the cost to employers is high, so they're moving towards a different model, like doing it through taxation. But that's something else, we can talk about it. Will these reforms travel? Is it easy to say, this is what is working in Germany, although Germany is reforming, France is reforming, Sweden is reforming, everybody's trying to do things a little bit differently. And I ask that question because having the United States as our neighbor, are we more likely to go to the strict manacled competition that they have in Germany, or would it be more in keeping with the competitive American model? And would the government regulate the system in the way that it's regulated very stringently in France as well as in Germany and Sweden? But I think the most important question is that are we in Canada willing to demand accountability and transparency? Because we pay billions and billions of dollars into the healthcare system. I'm not sure that it is a problem of money in the system. I think it's a problem of how it is organized. I think that we as citizens who are paying for this need to know a bit more about how the money is being spent, how wisely it's being spent. Now, the person on the street cannot assess that, but if this information was freely available, there are enough experts in the Canadian population who would be able to determine whether this money, which is our hard-earned dollars, Stockwell, they used to talk about sweat-stained dollars of workers. This is our money, and it is the government that is using it for a service that they're providing to us. So I guess the question is, would it be better, in fact, to pay a healthcare levy that is separate from our taxation so that we could actually follow the money and determine whether we were getting value for our money? Because I think our costs are getting higher and higher, and it seems as if the system is getting worse. Thank you.